Our next group of partners are from Purdue University and Indiana University. So this is a partnership between the academic institution from Purdue and the community partner is from Indiana University Health Positive Link. So to start us off is Dr. Monica Kasting. She's an assistant professor of public health at Purdue University and an associate member of the Cancer Prevention and Control Program at the Comprehensive Cancer Center. Her research has focused on examining predictors of hepatitis C virus, screening, human HPV vaccine uptake, and various determinants for preventive health decision making. And she'll be joined by Emily Brinegar. She's the manager of the prevention services at Indiana University Health Bloomington Positive Link. And she has worked in the area of HIV for 25 years. Currently, they provide HIV and HCV outreach and testing, as well as assist people in accessing PrEP and HCV treatment. So please join me in welcoming Dr. Kasting and followed by Emily Brinegar. Take it away.
Hi, thanks for having us. As Dr. Das said, I'm Monica Kasting from Purdue, and I'll be co-presenting with Emily Brinegar from IU Health Positive Link. Next slide, please. I don't want to repeat the background information from the webinar introduction, but what I do want to highlight is something that Richard also mentioned in his talk, which is that hepatitis C virus screening is universally recommended for all adults ages 18 to 79 years old. Next slide, please. And another thing is that this screening process actually includes 2 steps. So the first step is a Hep C antibody test. And if that's negative, the person is considered not to have hepatitis C and no follow-up testing is needed. If that is positive, they need a follow-up Hep C RNA test. And then if that's negative, it means they had Hep C at some point, but it has cleared on its own and they don't need treatment. But then if that follow-up test is positive, that means they have a current active infection and they need to be linked to care for treatment. Next slide. As stated in the introduction, there are many barriers to care and disparities for Hep C, including many NIMHD populations of interest. And a few additional things I want to further highlight is that some of the challenges to care include lack of awareness of infection, with half of people being unaware that they're infected, a lack of linkage to care. So only 43% of people who have tested positive have access to outpatient care. And then the price and access of treatment. So of all the people diagnosed, only about 9% of them achieve cure. Next slide. To bring it a little closer to home and orient all of you to what's happening in Indiana, which is circled there on the map in red, there's a publication of surveillance data from 2015 that reported that Indiana was one of 7 states that had acute Hep C infection rates that were at least twice the national average. So now since then, there's been a large investment and huge efforts towards Hep C elimination across the state. And I'll go through those quickly and highlight some of the efforts. So I think we can probably click 2 slides. Yeah. This is from a publication I worked on, led by my colleague, Dr. Lauren Nephew. We looked at changes in treatment rates over time, along with relevant policy changes. And on the left of the graph, starting in 2011, is when new direct-acting antiviral treatments started to be FDA approved. And you can see that treatment rates with just the approval and availability of treatments didn't improve too drastically. But on the contrary, the largest section there in the middle of the graph is when Indiana expanded Medicaid. And the very last section is when Medicaid treatment restrictions were removed for Hep C. So as you can see, we didn't see large improvement in treatment rates just when new drugs were simply available, but when we started to see large improvement was once those treatments were widely available and affordable for people. Next slide. Some community-based initiatives also happening in Indiana that I want to highlight include Connect to Cure, which is a linkage to care program for people in Indiana living with Hep C. In addition, they trained care coordinators to be community health workers and partnered with academic institutions and the Department of Corrections to get people who have tested positive into treatment. There's the Zero is Possible or ZIP Coalition, which are local coalitions aiming to end the HIV and Hep C epidemics in Indiana. And they aim to diagnose, treat, prevent, and respond quickly to outbreaks. Next slide, please. There's also a huge focus on provider trainings. So that aims to empower primary care providers in rural and underserved areas to treat their patients without having to send them to an academic medical center. Some of these efforts include our HCV ECHO, or Extension for Community Health Outcomes. It connects primary care providers to teams of medical experts to improve access to high quality Hep B and C treatment. And they meet for 1.5 hours twice a month. And then there's NHAMP, which is the Indiana Hepatitis Academic Mentorship Program, which trains primary care providers. It includes 2 8-hour trainings plus 2 of the 1.5 hour ECHO sessions. And then upon completion, providers can treat Hep C without needing to send this patient to a specialist. Next slide, please. All of these efforts across the state have made a difference. This is updated surveillance data from 2018 to 2022. So what I showed earlier was 2015. As you can see highlighted in the red box there, in 2018, the acute Hep C infection rate was 4 per 100,000, and by 2022, it was down to 2.2 per 100,000. Next slide, please. So I'm going to give a few examples of specific community-based research projects I worked on for Hep C. I have projects working with patient and community advisory boards, provider advisory boards, and community organizations like IU Health Positive Link. Next slide. Specifically, I worked on a community-based intervention development within one of our federally qualified health centers as part of a career development award I received. We targeted baby boomers for this project because at the time they were the age group that was universally recommended for screening. And we pulled data from the FQHC and found that only 15% of eligible patients had actually been screened. And I would actually consider this group of people really low-hanging fruit. They're connected to a provider, they're accessing healthcare, and even they weren't getting screened. So we decided to do an educational intervention to improve awareness of Hep C and screening recommendations, and developed a multi-level intervention and worked with a community advisory board and a provider advisory board to do this. Our community advisory board consisted of 4 members who were demographically representative of the FQHC. Median age was about 65. 3 of the 4 were female, 2 were Black, and 1 was Hispanic. And the provider advisory board consisted of 2 gastroenterologists and 2 primary care providers. 3 of the 4 were female, 1 was Black, and 1 was Hispanic. Next slide. So we developed a multi-level intervention. At the patient level, the intervention included a pre-visit reminder letter of their upcoming clinic visit, which included that they were recommended for Hep C screening, and then an educational flyer was in with the letter. And that included information about what hepatitis C is, what screening is, and why they need to be screened. And then we developed an educational video that they were given in the waiting room during their clinic visit. Their providers received a one-time lunch and learn educational session, followed by monthly performance feedback emails with their screening rates compared to overall rates in their clinics. Next slide. Our community advisory board provided input and feedback on the patient level intervention, and they gave feedback on content, modality, graphics, pace, length, and what information is important to them. And providers gave feedback on similar constructs, content, modality, in-clinic implementation, preferences for contact, important information. The feedback wasn't always specific to content. I'll give you an example of that we can go to the next slide. So this is an example. It was just a stock photo we had as part of the educational video for patients. It was really just meant to fill white space, but we started with the picture on the left, and the advisory board did not like it at all. They expressed doubt that anyone in their age group could or would attempt to jump that high, and they didn't like that the people were not demographically reflective of the patient population. So we ended up changing that picture to the one on the right, which was much more acceptable to them. They said the people in that picture looked happy and seemed to be relatable. Next slide. So we did cognitive debriefing interviews afterwards and found that the intervention was feasible, acceptable, and usable to relevant stakeholders. We did both patients and providers for these interviews. And the citation with the full findings from the cognitive debriefing interviews and intervention development is there if you'd like further information on that. Next slide. So some rules of thumb for successful community academic partnerships include involving the partner really early in the process. I've noticed a lot of times academics have these ideas in mind and develop it and then take it to the community partner, and then the community partner says there's no way that can work with their clinic flow or with the way with what the population needs. So involving them early is crucial. Having a clear understanding of the project and expectations on both sides. I myself make myself available for activities outside of the research for the community partner. That includes going to health fairs or giving expert talks if they need me to. Having a clear communication plan and following through on responsibilities, and then listening to them as the expert and appreciating their insights. Next slide, please. The community partners and research both bring unique expertise to the team. The community partner really has the deep knowledge of the population and the unique contextual barriers they're facing, as well as the knowledge of the clinic flow and their model of care. And the researcher has the topical expertise and the evaluation and grant writing skills and knowledge of implementation of national efforts and programs. Next slide, please. So, building on my community-based work for the in-clinic educational intervention, I've now started a new project that will reach beyond that low-hanging fruit people who are already accessing healthcare, for a new project that will work with harder to reach populations who may not be readily accessing healthcare. So either people experiencing homelessness, people without access to medical care. And this is a collaboration with biomedical engineers at Purdue and our community partner Positive Link. Our biomedical engineering colleague, Dr. Jackie Linus, has a point of care diagnostic test for HIV that can be modified to work for hepatitis C, which would cut out the need for the antibody test and the need to send the RNA PCR test to a lab for results. However, most diagnostic tests are developed without input from the end users. So we're involving our community organizations, patients, and providers in the development process of the point of care test to ensure the end product is one that's feasible, acceptable, and usable to key stakeholders and can be readily implemented in the clinic. Our primary community partner for this is Positive Link, who we've worked with starting with the initial grant writing process. And now I'm going to pass it off to Emily for some more background on the great work they do and her experience with some academic partnerships.
Thanks, Dr. Kasting. Hi, yes, my name is Emily Brinegar. I am the manager for prevention services at IU Health Positive Link. Next slide, please. So I'll just briefly go over the kind of who we are, what we do, so I can focus a little bit more on what we have been seeing that's working in getting folks engaged in care around Hep C treatment, as well as some things that we have learned over the years in partnering with researchers. So we are an AIDS service organization is how we started many years ago, back in the early 90s. We began doing HCV testing probably around 2009, 2010. And it is more and more becoming a greater part of the work that we do. And that's not just within our organization, but really with pretty much all of the AIDS service organizations here in Indiana. But we provide HIV, Hep C, and STI testing and treatment. We do linkage to care for HIV and HCV medical care. We also can do linkage for PrEP and PEP for HIV. We have medical, non-medical case management for people with living with HIV. More recently, in the last couple of years, we've begun doing care coordination for people living with Hep C. We also have a small department that does financial and housing case management for people living with HIV. Next slide, please. Lastly, one of our newest additions is our medical clinic. We provide HIV primary care, so not specialized infectious disease care in most situations, but HIV primary care, Hep C treatment, and access to PrEP. Just a little bit more background about who we are. So as I noted, we were founded in the early 90s, 91. Our main office is in Bloomington, Indiana. It's the home of Indiana University. We're kind of in the South Central region of the state. But we have offices in areas all around the state, kind of not so much in the central Indianapolis urban area, but really all of the kind of central Indiana areas around there. So IU Health is part of we are the largest health network in Indiana. That said, we function pretty much like a standalone community-based organization. We do get support from the hospital, but our day-to-day looks a lot less like a hospital clinic and more like a community-based organization. We're 90% grant funded. Other kind of things to note, we serve 51 counties in Indiana. They're predominantly rural. Our counties have a population of anywhere from 12,000 to 186,000. So I'm sure for those of you in California, that seems quite small. Most of our funding is federal pass-through grants that come through the Indiana Department of Health, so CDC, HRSA, HUD, SAMHSA. We also have some grants through a fewer smaller and private foundations. Next slide, please. So getting into the populations that we serve, so all funding is directed to reaching those who are at the greatest risk for HIV and hepatitis C. In Indiana, primarily, that is men who have sex with men of all races and ethnicities. For HIV, we have seen the rate of HCV increase in that population as well. Individuals who use injection drugs, really large population there, as well as adolescents. We're seeing risk in adolescents kind of all over the board. So it's no longer, just either, young men who have sex with men. We're seeing all kinds of risk amongst adolescents. And where we reach these populations, we go to where the people are. And I loved hearing Richard and Jordan both noted there was a lot in their presentations about just you have to get to the people. And I absolutely agree. So street encampment outreach, we go to bars, we go to substance use treatment programs, university events, population specific events, and syringe services programs, huge for Hep C. Our partnerships with our SSP friends are really integral in a lot of the work that we're doing around Hep C. Next slide, please. So our approach, I'm actually going to start with that bottom one, harm reduction. And this goes within all of our programming. We really work from a harm reduction approach. So we know that we really need to start where the patient is. We need to start with their priorities, and we need to build their trust in order for us to then be able to provide them the services that we know that they likely need, but they may not have a clue that they need yet. And that includes things like hepatitis C testing, hepatitis C treatment. So we utilize research recognized best practices in the work that we do. Again, that big thing of bringing services to the people rather than expecting them to come to us. By no means is this foolproof, because we don't work in systems that are set up to do that. So it takes a lot of work. It takes a lot of piecing things together to make that happen. And it's something that we strive to continually develop, as well as developing relationships with other community partners, agencies and stakeholders in the populations we're trying to reach. And we've really found that starting that relationship with asking how we can help. Not telling them how we can help, but looking really to see where their priorities are first and seeing how we can mesh those priorities. Recent programs that have worked and are working, some of these are very, very new. So I want to be upfront about that. Drive-up rapid testing for HIV and Hep C is something that we started during the COVID-19 pandemic. We are in a outpatient medical clinic setting. you know, there was no preventative medicine happening. We couldn't get people in for testing unless, you know, it was really almost an emergency. We were like, how are we going to still do our jobs? And we developed a way to do, we do a lot of rapid testing of how to do that on a drive-up basis. Drive around to the side of the building, call the number, do risk reduction, counseling, talk about, you know, concerns, needs over the phone. The tester goes out, they do the mouth swab or the finger stick, they go back inside, they let the test run, they call the person back. If they need to go back out, they do. If not, they might be able to, you know, do any of that follow-up education and referral over the phone. If there's a reactive test, we absolutely would bring the person inside at that point. But we continued to do that because it was so effective. And I think it's just a really good example of one of those things that you know, we had to be pushed to a point where we had to get really creative before we found a new way to do something, and it stuck, and we still do it. Street and encampment outreach. So that is something we also started doing more of during the pandemic, really knowing that, you know, people who even had the ability to get to us weren't going to get to us. So especially people who had a lot of barriers, a lot of health disparities, you know, including those who are unhoused, were really going to have difficulty getting to us. So worked with some other of our local community partners, including our SSPs, to really build that up. And then with our HCV care coordination, so the Connect to Cure initiative that Monica mentioned, this has been newer in the last really just year and a half is when the big expansion has happened. And I'll talk a little bit more about that in a second. But another thing that is very new within our IU health system is all of our emergency departments around the state are now doing universal HIV and HCV screening. That maybe, I don't know, is something that is done more commonly around the country. It was not done here. So now everyone who does not have a documented HIV or Hep C test on file is offered testing. Next screen, please. So I really wanted to focus on this HCV care coordination piece. So basically what it is medical case management for people living with HCV who want to be treated for Hep C. The Connect to Cure initiative really helped expand that across Indiana. We were able to hire in early 2023 6 new Hep C care coordinators. We had one as part of kind of a couple-year trial project that our State Department of Health was running, and it was going pretty well, but we didn't have the infrastructure around it. We didn't have enough providers to refer to. We didn't have, we were really building that system of care based on HIV care coordination, which honestly, there are a lot of similarities, and that model of care does fit pretty well. There are some, you know, things that are a little bit different with Hep C for sure. One, in theory, hopefully, this is going to be a short-term relationship with the care coordinators. You know, treatment now is 60 to 90 days. And so our hope is that from the time we get a client, we only have them in our case management services for about 6 months. What those care coordinators really do is help address their barriers to care. That can be a number of things, going back to asking them what they need. First of all, they may not know much about Hep C. They may not know what it does, how it impacts them, why it's important to get treated, how it's transmitted. Alternatively, we find a lot of people who have actually been living with Hep C for a long time. And by a long time, I mean, you know, 5 to 10 years maybe. They had no idea they could get treated because the treatment has changed so much just in the last several years. So, or they've had providers tell them, no, you can't get treated. I'm not treating you until, you know, you've had a certain number of years where you haven't been using substances. We know that that is not the recommendation now. Treat people as soon and as early as we can is the way that we really want to go. As far as other barriers, access to telehealth has been one of the biggest successes for us. We've had some clients, our care coordinators have maybe not even met face to face in person because we have just figured out how we can get all of this done. Virtually. We're fortunate. It was not an easy thing to get set up actually, but we're fortunate that we have that availability for folks. And it's been really effective and really helpful, especially again, we work with a lot of folks in really rural areas. So, no public transportation, not just bad public transportation, just non-existent. We have many counties, they don't have Uber. So that transportation component can be really huge. We can also send the care coordinators out to folks. One of the things that I really love about this Connected Care program as well, while we're part of a big medical system, we have providers that treat Hep C. If there is a provider closer to the person that is willing to treat HCV, that wants to do it, we'll have our care coordinators work with them regardless of who the provider is. They don't have to necessarily be within our IU Health services network. And it kind of seems like a little thing, but in the grand scheme of, large healthcare and corporate healthcare in these days, sometimes that can be more difficult. So we just want to eliminate as many of those barriers as we can to get people into care. Our care coordination services are currently free of charge. I anticipate they will hopefully always be free of charge to the patient. However, Monica had mentioned that we have been in the process of getting our care coordinators trained to be certified community health workers. Community health workers are actually billable towards Medicaid and insurance now in Indiana. That's a very, very new thing. So that system is still being set up. So we're hopeful that in the long run, that might be something that we'll be able to utilize as well to, offset that cost as this program is grant funded. And, I'm preaching to the choir when I say that changes frequently.
Can you wrap up? We have about a minute left.
Okay, so sorry. Let's see, next slide, please. Let's go ahead to that next slide, the one with the graphs. So I won't focus on this. It will be in the slide deck. This just shows a little bit about what we've done. Again, all of this data, this slide is really just between probably May, June of 2023 and March of this year. So really kind of our first year of providing these services. And I think the big one to focus on here is that in that time, we had 99 people start on Hep C treatment. And by March of this year, 39 had completed treatment. I mean, thinking it was a very new program, we've got, it's September, October before we're even seeing people complete treatment at that point. And by March, we had 35 people who had actually completed their SVR12 labs, which is that lab that we do 3 months post-treatment to be sure that they have in fact cleared the infection. Last slide. Okay, so sorry, the partnership with academic partners, and really Monica touched on all of this. The fact that while our goals are typically the same, the method often isn't. So involving community partners as early as possible in your research planning, I think is really, really key, and having those very transparent conversations. I think sometimes community organizations were like, we want to please the researcher. We know we need your help. This research needs to be done because the money follows the research. But coming into that collaboration, just being very transparent with each other of what the goals are, what you hope to outcome, and to be sure that we can meet the needs of what the research is hoping to do, how it's designed, so that it really, works the best for both of us. So thank you so much for having me.
Thank you, Emily. And we have 2